Bismillah ar-Rahman ar-Rahim. We started a series about the cardiac shunts. In the first video, we talked about the Fick principle and how to use this principle to measure the systemic and pulmonary blood flows. In the second video, we talked about the cardiac shunts, and I think now we are ready to discuss the confirmation and the quantification of the cardiac shunts, and also to decide the severity and significance to decide whether this patient is for repair or not. If we suspect that we have a shunt, we need to have answers to the following questions. Do we have a shunt, really? Is the shunt right to left causing desaturation, or the shunt is left to right and causing pulmonary plethora, heart failure signs, and risk of pulmonary hypertension? How significant it is, and if it is left to right shunt, has it raised the pulmonary vascular resistance or not yet? And if the pulmonary vascular resistance is already high, is this reversible or irreversible? So we take all these answers and the team will decide whether the patient is for repair or not. So if the patient doesn't have very high irreversible increase in pulmonary vascular resistance, so in that case it is safe to repair. Also, on the other side, small significant shunt could be for conservative treatment and follow-up, because some of these shunts could just close spontaneously with time. In the middle between the two situations, the very high irreversible pulmonary vascular resistance and the very small insignificant shunt, the urgency of the surgery or the repair needs to be decided according to the significance of the shunt and according to the risk of developing pulmonary hypertension. Now imagine that we have a child with pulmonary plethora, increased work of breathing, symptoms and signs of heart failure. In that case, we suspected that there is a left to right shunt. So the first thing to be done would be an echo examination. The echo can show if there is a VCD or not. It is really uncommon to do cardiac catheter just to confirm the presence or absence of a shunt. The echo can comment on the anatomical defect size, the direction of the flow, whether it is left to right or right to left or bidirectional. The shunt character, is it restrictive or non-restrictive? It is usually done by seeing the velocity across the defect and see if there is a high pressure gradient. If there is a high pressure gradient, that means there is a big difference between the pressure on either sides of the shunt. For example, if you have a VCD between the left ventricle and right ventricle, normally the left ventricular pressure is much higher than the right ventricular pressure. If you have a VCD, you will say that this VCD is non-restrictive if you find that the right ventricular pressure is high, much higher than normal. It is approaching the pressure in the left ventricle. So in that case, you say that we have a big VCD and this VCD is non-restrictive because the pressure in the left ventricle is reflected to the right ventricle, and also it will be reflected to the pulmonary circulation, so the pulmonary circulation will be exposed to this high pressure. On the other hand, if we have a small VCD and this VCD is preventing or protecting the right side of the heart from the high pressure in the left ventricle, so in that case we will say that this shunt is restrictive shunt. The same situation will be if we have a PDA and we just compare the pressures in the aorta with the pressure in the pulmonary artery and see if the high pressure in the aorta is reflected to the pulmonary artery or not. So in some cases the echo is not enough, and if we have a doubt that there's a shunt or not, the cardiac catheter will confirm the shunt and it will tell us where is the shunt and how big it is and significant it is. Also, the cardiac catheter will measure the pulmonary artery pressure, and if this pulmonary artery pressure is high, it will also give us the chance to measure the pulmonary vascular resistance and decide whether this high pulmonary pressure is because of the abnormal communication between the left side of the heart and the pulmonary circulation, or this high pulmonary pressure is just because of the high pulmonary vascular resistance developed by the high pulmonary blood flow because of this shunt and because of the recirculation of blood in the pulmonary circulation. Now, a quick overview of the diagnostic cardiac catheter. The diagnostic cardiac catheter is simply just using a big vein in case of the right heart catheterization or a big artery in case of the left heart catheterization to pass a catheter. First, if we use the vein and the right heart catheterization, this catheter will go from the big vein to the systemic veins, SFC or IVC, to the right atrium, right ventricle, pulmonary artery branches, and it ends at the terminal branches of the pulmonary arteries to measure the pulmonary capillary wedge pressure. On the left side, we use a big artery, and this artery will enable the catheter to go to the aorta, to the ascending aorta, through the aortic valve to the left ventricle, to the left atrium, to the pulmonary veins. These catheters will enable us to take blood samples to measure the oxygen saturation, to measure the pressures in different locations, and also to inject dye. And this dye, we can trace this dye by using X-ray to give us a film of the spread of this dye. If we suspected that there is a shunt, but we couldn't see it with the echo, they do oxygen saturation screening, which is just taking blood samples from the SVC, from the main pulmonary artery, and from the aorta, and see the saturation readings, and see if these saturation readings make sense. Is it normal or it is abnormal? And if it is abnormal, that means there is a shunt. And the second step now is to see where is the shunt and to quantify it. If we already know that there is a shunt and we need to confirm its site and significance, so multiple samples of blood are taken from the right atrium, from the right ventricle, from the main pulmonary artery, from the left atrium, from the aorta. And in that case, we may find that the oxygen saturation in the right atrium is higher than what is expected. We say in this case that the oxygen saturation has oxygen saturation step up. So there is oxygenated blood coming to the right atrium from the other side. So we suspect now that there is an ASD shunting left to right, or there is abnormal pulmonary veins draining into the right side instead of draining into the left atrium. Another example of oxygen saturation step up is a normal saturation in the right atrium, but abnormally high saturation in the right ventricle. And in that case, we will say, no, this is not an ASD. This is most probably this is a VSD, because the oxygen saturation was normal at the right atrial location, but the oxygen saturation has risen up in the right ventricle. So we say this is oxygen saturation step up at the right ventricular level. So we suspect in that case that there is a VSD shunting left to right. Examples of oxygen saturation step down is if we found like low oxygen saturation in the left ventricle, while the left atrial saturation was normal. So we measured left atrial saturation, it was normal, but we found that the oxygen saturation in the left ventricle dropped. So in that case, that means that there is a desaturated blood coming from the right ventricle to the left ventricle through a VSD, and there is a right to left shunt. Now, after taking the oxygen saturation samples, we know that there is a shunt. We decided its location and its direction of flow, whether it is left to right or right to left or bidirectional. But how significant the shunt is. The size of the defect, is it small or large by the echo? The pressure gradient measured across the shunt using the Bernoulli equation by the echo. Is it just measuring the velocity of blood across this anatomical shunt and using this velocity? So the square of this velocity multiplied by 4 will give us the pressure gradient, or the difference in the pressure between the two sides of the shunt. For example, if I have a PDA, I know that the aortic pressure from the arterial measurement is 60, and the echo said that the pressure gradient is 20. So in that case, that means the pressure difference between the aorta and the pulmonary through this PDA is 20 minus 60. That means the pulmonary artery pressure is 40. So this is how we use the Bernoulli equation to see if this shunt is restrictive or non-restrictive. The other thing is using the data from the X-ray. So the X-ray, if the lung looks plethoric or congested, that means that we have a significant shunt. We have a left to right shunt, and the pulmonary blood flow is high. And also the symptoms of the patient. If the patient has symptoms of heart failure and increased work of breathing, all of this will give an idea about the significance of the shunt. From the cardiac catheter, the angiography can show us how big or small the shunt is as well. But all these data are useful, but the QPQS is the most useful measure to quantify the shunt and to know its significance. So what is the QPQS? So in the first lecture of this group, I talked about the QPQS, the effect principle, and how we can use this to measure the QPQS. Q means flow and P pulmonary, so QP is the pulmonary blood flow and the QS is the systemic blood flow, and we can use the data, the oxygen saturation data collected from multiple sites during the cardiac catheter to measure the QP and measure the QS. And just the difference between the QP and the QS is the shunt actually. So QP minus QS, this is the shunt. In normal patients, the pulmonary blood flow equals the systemic blood flow. So QP equals QS, and this is the normal. And the other parameter we use, the QP QS ratio, will be 1 in this situation. If we have a left to right shunt, in that case the pulmonary blood flow will be higher than the systemic blood flow, so the QP will be higher than the QS, and the ratio of QP to QS will be more than 1. On the other side, if we have a right to left shunt, so the QP will be less than the QS. Systemic blood flow will be higher than pulmonary blood flow because there is some blood shunting right to left. And in that case, the QP-QS ratio will be less than 1. Now, in case if we have a left to right shunt, we need to know the significance of this shunt. So by measuring the QP-QS, we can say if the QP-QS is 1.25 to 1.5, that means it is a small shunt. And if the QP-QS is anything more than 2, this means it is a large significant shunt. Now I want to explain a point related to the left to right shunt. When you have a left to right shunt, this causes high pulmonary blood flow, and this is in the beginning. This high pulmonary blood flow, sometimes it is just high pulmonary blood flow, or it is high pulmonary blood flow and also high pressure. So the pulmonary circulation is exposed to the high pressure transmitted through the defect from the left ventricle in case of VSD, or transmitted through the defect from the aorta in case of PDA and truncus arteriosus. This does not mean that the pulmonary vascular resistance of this patient now is high. This is the beginning of every left to right shunt. So either left to right shunt with only high pulmonary blood flow, which is the case of ASD, or a patient who has a VSD or PDA or truncus arteriosus, and the pulmonary circulation is exposed to high pulmonary blood flow and also exposed to high pressure from the left ventricle or the aorta. In the first patient, the development of permanent pulmonary vascular changes is very slow, and it takes years and years, and it even can develop in adult age or even in elderly patient, like the ASD. And that's why the ASD, the patient with the ASD can tolerate for a long time without development of pulmonary hypertension and high pulmonary vascular resistance. But on the other hand, the patient with VCD or PDA or truncus arteriosus, I mean the defects are big and non-restrictive. So this patient will develop pulmonary vascular changes faster than the first one because of the exposure to the high flow and the high pressure. In the second patient, I have a patient coming to me, and in the cardiac catheter, I will find that the pulmonary artery pressure is high. Whether this high pulmonary pressure is because of the transmitted pressure from the aorta or the left ventricle, or this is an already high blood pressure because of the increased pulmonary vascular resistance, I can't differentiate between those two patients because both patients will have a high pulmonary artery pressure. So in this case, I have two scenarios. One patient with low or normal pulmonary vascular resistance, high QBQS, and left to right shunt with high pulmonary blood pressure, of course. And the other patient, high pulmonary blood pressure, but with high pulmonary vascular resistance. And because of this high pulmonary vascular resistance, the pulmonary blood flow or the QBQS started to go down. So this patient may have a QBQS of normal or low QBQS, high pulmonary vascular resistance, and high pulmonary blood pressure. How I can differentiate between those two patients? Because it makes a big difference regarding the decision of the surgery. The patient who developed high pulmonary vascular resistance is contraindicated for surgery, and the patient who has high pulmonary blood pressure because of just the high flow and the transmitted pressure without development of permanent high pulmonary vascular resistance, so this patient is still amenable for repair. So also, if the patient developed pulmonary vascular resistance, I need to know how serious it is. Is this like severe increase the pulmonary vascular resistance or mild to moderate increase in the pulmonary vascular resistance? Because if the pulmonary vascular resistance is normal, this patient is for repair. If the pulmonary vascular resistance is mildly increased, this patient is still for repair, but it will be a high-risk patient. But if the pulmonary vascular resistance is severe, is severely increased, in that case, this patient is contraindicated for surgery. So that's why we need to know the QBQS to differentiate between those two patients, and we need to know the pulmonary vascular resistance to see if it is normal, mildly increased, moderately increased, or severely increased. And we need also to know if this increase in the pulmonary vascular resistance is just because of the situation that the patient on, and also if this increase the pulmonary vascular resistance is just temporary vasoconstriction of the blood vessels, not permanent changes in the vessels. And we can do that by exposing the patient to oxygen. We know that oxygen is a strong pulmonary vasodilator, and also we can use nitric oxide. So we usually do all the measurements of the pressures and the pulmonary vascular resistance on room air or the least FiO2 that we can. And after that, we can repeat all the measurements after putting the patient on 100% oxygen and nitric oxide if available for 10 minutes, and then repeat all the measurements again and see if this increase in the pulmonary vascular resistance is reversible or not. So a high pulmonary vascular resistance that is irreversible is a contraindication for surgery because it will end up with acute right ventricular failure if we close the defect. A patient with low pulmonary vascular resistance is for repair. A patient with moderate to high pulmonary vascular resistance that is reversible is still for repair, but this patient will be a high-risk patient that will need careful intra and post-operative management. This patient may need nitric oxide at the end of the surgery. This patient may need a longer ventilation in the intensive care, and also, of course, this patient is not a good candidate for fast tracking or extubation on the table. These are the calculations usually used in the cardiac catheter after getting the pressure measurements to decide the situation of the patient. I believe myself that the good pediatric cardiac anesthetist, who is the one who has a good understanding of the cardiac lesions, he is on the same page with the cardiology team and with the surgical team. He knows how they take their decisions, and this is crucial for the anesthetic management of those patients. So the accurate data is crucial for taking decisions regarding the suitability for cardiac surgery or just to leave the patient alone without surgery. So the accuracy of data could be seriously affected by changes in the hemodynamics, like massive increase in the heart rate or blood pressure. This will definitely affect the measurements, and it will give an inaccurate picture about the condition of the patient. Also the ventilation. So we know that the PO2, PCO2, lung volumes, and pH has a marked effect on the pulmonary circulation. So if these parameters are not within normal ranges while taking these measurements, that means these measurements will not be accurate at all. And I think that's why in some cardiac centers, in some cath labs, it is routine to take arterial blood gas and see if it needs any optimization before taking the measurements. To know the significance of the effect of oxygen on the QPQS ratio, when you review the cardiac catheter data report, you may see a patient with a QPQS of 2 on room air. But when we repeat this data on 100% oxygen, you can easily find that the QPQS becomes 20. Can you imagine how significant is the effect of oxygen on the balance between the systemic and the pulmonary blood flow? From QP double the QS on room air to QP 20 times the QS on 100% oxygen. And this also shows the significance of using low FiO2, avoiding hyperventilation, or even accepting mildly higher CO2, using low ventilation during anesthesia of the left to right shunts. And all of this is just to avoid this high pulmonary blood flow that would steal from the systemic side, this high recirculation of blood in the pulmonary blood that will steal from the systemic side, and it will cause load on the heart. And this recirculation can significantly affect the perfusion of the systemic organs, in particular the coronary blood flow. It is also important to make the calculations on the lowest oxygen possible, and this is to decrease the inaccuracy that could be caused by not including the dissolved oxygen in the calculation. We know that the oxygen content equation is used while we measure the QP and QS. And this oxygen content equation has part of oxygen loaded on the hemoglobin and part of oxygen is dissolved in the plasma. And this part dissolved in the plasma is using the PO2 or the oxygen dissolved in the plasma. The more we give oxygen, the more we use a high FiO2, the more the dissolved oxygen in the plasma part, and this can cause inaccuracy in the calculations. Another point is the effect of oxygen on the pulmonary vascular resistance. As we can see now that the oxygen is a very strong pulmonary vasodilator, and using high FiO2 will give inaccurate measure of the pulmonary vascular resistance. Of course, if I have a patient with a bad lung and I'm not able to ventilate the patient just with room air, I can use a higher FiO2 to keep the patient alive, of course, but I will inform the cardiology team so they can modify the calculations and write this in their report. Now this is the end of this video. This is the third video of 3 videos talking about the QBQS and the cardiac shunts and how to quantify the shunt and take the decision for the surgery. I enjoyed this topic. I believe this is a very, very important topic to understand lots of things in the pediatric cardiac anesthesia. And I hope that you enjoyed it, and I hope it is useful for anyone. Please, if I have done any mistake, please comment on that. Just correct my mistakes, and thank you for listening, and have a nice day.